oncologist from Switzerland with experience in pathology during my residency. I'm now doing 2 years of research in Vancouver, where I basically did bioinformatics and genomics of bladder cancer. And maybe about 4 years ago, we started profiling bladder cancer specimens or biopsies prior to neoadjuvant chemotherapy, and we started investigating these samples and these genomic profiles, trying to understand the likelihood of response to neoadjuvant chemotherapy. And we ended up with there are 4 original methods for molecular subtyping, and we ended up kind of analyzing all of these 4 methods and then coming together with a consensus subtype, combining all these 4 methods, building these consensus classes that are namely Claudin low, which is a subtype of the basal group. Then the basal tumor is luminal infiltrated and luminal. And what we could see when comparing patient outcomes between a chemotherapy treated cohort like ours, which is a bit more than 300 patients, compared to a cohort of patients that did not receive neoadjuvant chemotherapy, then we could see that the prognosis of patients with basal tumors was dramatically improved when they received neoadjuvant chemotherapy, which is basically our main finding, that we will be able to use our test in a single sample setting, so in a single patient tumor, to assign this tumor to a given molecular subtype. And if this subtype is predicted to be basal, then the patient is very likely to benefit from neoadjuvant chemotherapy. We will move on being more personalized. In bladder cancer, this method of molecular subtyping or molecular characterization of bladder cancer is maybe 5 to 6 years old, and prior to that, bladder cancer was bladder cancer, and you treat it all the same way, all with the same medication, and this is something that will be changed in the next few years, where we will be more personalized either to a given subtype or to a specific mutation. Maybe as a side story, we just published a study on HER2 in bladder cancer and could see that there might be patients or tumors that benefit from HER2, but it's very important to be very specific and to be very kind of accurate in profiling, in examining or analyzing these tumors. So the main change will be that instead of treating bladder cancer, we will treat a specific biology within a bladder cancer. The biggest challenge will be to kind of move on from biomarker in a preclinical setting to move on and bring these biomarkers into the clinical trial, into daily clinical use. None of the biomarkers were actually being tested in any prospective randomized trial, same as ours. Ours is retrospective data, so urgently needs ideally prospective validation. This will be the biggest challenge for our study.